We are live, ma'am.
Okay. Good evening, everyone. Welcome to the second webinar of the Diabetes and Women's Interest Group of Diabetes India. As you all are aware, cardiovascular disease is a major cause of death in women, especially those with diabetes, especially Asian Indian women. Leave alone the manifestations of cardiovascular disease in the women. The quality of life is severely compromised, and the awareness amongst the care providers themselves is so low that the general public may not even be expected to know about the increased risk. There is a lower rate of inclusion even in clinical trials for women. And simple things that are impactful, like prescribing statins or blood thinners, is dismal amongst women. Hence, such webinars that bring out the nuances or perspectives of providing better care to women, especially today's with a focus on cardiovascular disease, are welcome and they are important. Keeping these factors for treating women in mind is very, very critical. And I'm so thankful to our president, Sir Dr. S.R. Arvind, sir, Dr. Banshi Sabu, sir, our national secretary, Dr. Amit Gupta, who's the joint secretary of Diabetes India, and also the mastermind behind these interest groups for assigning this responsibility to me. I'm equally thankful to Dr. Rutul Goklani, Dr. Manoj Chawla, and the entire team, Dr. Abha Gupta, Dr. Ripun Sir, Dr. Ami Sanghvi, and Dr. Minakshi Bajaj, of course, and Dr. Sunil Gupta, our advisor. But amongst persons who really made this happen today, I cannot thank Dr. Usha Shriram ma'am more for making this happen today. Dr. Meena Chabra ma'am, of course, Dr. Annabelle Wogman, Dr. Lotika Purohit, and Dr. Dhruvi Hasnani. And the main reason we are doing it now is to commemorate our dear late respected Dr. Benny Neglur ma'am, a stoic champion of women's health who we lost too soon. A webinar focusing on women's health is probably the perfect tribute as we, her followers, her disciples, and her admirers could think of doing for her. And she would have loved this kind of a webinar with the faculty that we have today. So thank you all for being such a huge part of this. And without much ado, I invite Dr. Banshi Sabu sir to give us his opening remarks.
Thank you, Purvi. First of all, thanks for doing this wonderful webinar. And we are remembering our very close friend, our dear sister, Dr. Benny Neglu. So again, thanking you, Purvi, that you are dedicating this webinar on her day. We are very, very, thankful to everyone, all the faculty members that today we all are joining here for this afternoon webinar. As you have already rightly said, the diabetes in women, they have higher risk of developing cardiovascular disease, and the Indian data and Southeast Asian data is also showing that we are having this problem more and more. And I think it requires more awareness and education. In India, still physicians, they think that they don't develop the problem. And that's the reason many of the times they are not investigated for the same. Its women issues are multiples. Even sometimes we have seen not post-menopausal, even pre-menopausal women also developing coronary artery disease. So it's a high index of suspicion is the only way. We see as a diabetes patient, so diabetic patients are no more protected. That also we should know that. And this information and message should go through webinar only. I will not say that physically it will not be possible because in your room maybe 100, 200 physicians may be there. But when it's a webinar, you are actually connected to thousands of the doctors. You know that on every meeting which we are doing or any webinar meeting, at that point of time, maybe few hundred doctors are joining, but because it remains on our website or the link, so thousands of the doctors, they continue to learn whatever we have discussed. So this online webinar post-COVID has really, our reach is now much more in compared to what we were doing before. Whatever we were doing before. Now we are reaching out to thousands of the doctors across the country. So I'm very happy and we have taken very right time initiative for this. And I hope that other interest group, they also follow you, and more such programs are required under this banner of diabetes and women. Thanking everyone, all the faculty members, and particular thanks to Purvi and Rutul for organizing, and extremely thankful to our very close friend Dr. Vijay Negru for accepting our invitation and to be here with us, and Dr. Usha Shriram. And now over to Dr. Purvi for further proceedings.
Thank you so much, sir. I did forget to mention that sir is also the IDF Southeast Asia chair, and he has a much wider perspective, and I think he's
The
been
next time we will invite in diabetes and women group, few people invited from Bangladesh, Nepal, Sri Lanka, and they can be also the part.
Absolutely, absolutely,
So the
sir.
next meeting you plan in such a way that it will be a diabetes and women webinar by Diabetes India, and we will invite from Southeast Asia or from other Asian countries to be part of it.
Absolutely, sir. Well noted. And that's how we began in the month of January. In February itself, we had our first webinar with all of them, and we'll have them again for the next one as well.
Great.
And with that, I invite Dr. Amit to share his thoughts on the webinar and the
But then
topic.
don't forget Amit also to introduce that he is not only a joint secretary for Diabetes India, he is chair of Diabetes School of International Diabetic Federation.
Oh,
So that's a proud moment for all of us, and he's a chair for IDF school. So I mean, when you introduce Amit as a joint secretary for Diabetes India, but much bigger position is now he's IDF chair also.
Absolutely. And I think the halo speaks for itself.
Exactly. Now it is reaching up to America, US.
mm,
The US had come out with a global advisory board.
good.
You will be all happy to know that with that global advisory board, he's the secretary. So like I was, in ESDA, I am part of the global advisory board. But Amit had started this global advisory board of US, which is done by American Diabetic Association, and he's the secretary general of that global advisory. So congratulations, Amit, and now introduce on behalf of Diabetes India, your talk.
Sir, thank you very much, sir. And you have been very kind, and I really appreciate. And you have been a mentor to me, and it is really it is not my achievement; it is your achievement. And
It's a Diabetes India achievement. It's an India achievement.
yes.
We
So
all are proud of it.
I'm
We all
thankful
feel
to
that we had become the part of ADA. It's
yes.
not like that you had become part of. We feel that we had become
Yes.
the part of ADA.
So I'm thankful to all of you and Vijay sir, the Usha Shriram ma'am, and Dr. Purvi. I really appreciate this webinar because when we started this interest group, so I would just like to speak about the interest group first. And the idea was not to keep it as a diabetes and pregnancy study group or something like that. So because what happens, especially in the field of diabetes, whenever we talk about women health, most often the discussion revolves around only around the pregnancy and many other things. They are often overlooked, and this is also happening in our conferences because seldom other topics are being discussed, whether it is osteoporosis or whether it is cancers or you have CVD or multiple other aspects of the care which are required. So I think this is a perfect start. Last time, I guess we had a very good international webinar, and we had friends from Pakistan, we had friends from other countries as well, and the Southeast Asia region was well represented in that webinar. And today again, we have the international speakers and the national speakers in this webinar, and the entire lineup is very strongly made up. So I think everyone will benefit from this webinar. And in next 2 hours, certainly our knowledge regarding the care of women with diabetes is going to improve, and this is going to improve our clinical practice as well. So all the best to this interest group, Dr. Rutul, Dr. Purvi, and all the committee members of the interest group. So they are doing amazing work, and keep doing that. And the next webinar has already been given. You have already been given the hint by Dr. Bansi sir that how it is to be planned. So I'm sure it will also happen in a short period of time. So over to you, Dr. Purvi,
Idea
ma'am.
of Southeast Asia. Now it will be with the idea of Southeast Asia.
Yes, yes. Right.
Absolutely. Thank you so much. Uh, and on behalf of all of us here today, I would like to invite Dr. Vijay Neglu, sir, who has so kindly accepted to be here today. It has been difficult for all of us. And recently, it was Dr. Benny Ma'am's birth anniversary, and we spent the entire day actually thinking about her and her mission, especially on the professional front. So, if you would like to share some thoughts, we would love that.
Thank you, Dr. Purvi, for your kind words. Thanks everybody on the board, Dr. Bansi, Dr. Amit, Dr. Usha Shriram, Dr. Meena, and Dr. Dhruvi, and anybody I missed out, Dr. Ripon, and so on and so forth. You know, there's a saying in Sanskrit, Yatra Naryaha Pujyante, Tatra Devaha Ramante. That means where women are worshipped, the gods stay there. Women are so important part of our life because they not only are mothers, but they also take care of everything else. What Benny used to say, that if you educate one woman, you educate the nation. That's what she used to tell in every meeting that she used to attend for women on diabetes. And therefore, this CME, I think, is the most befitting tribute in her name because she really had worked hard on the women in diabetes, in the emancipation of a lot of problems that women faced, not only because of the disease or because of the health illiteracy. The health illiteracy was the most important burning issue, according to her. And she wanted to see that every woman that she says or she sees has to be so well educated about her disease that she gives a good account to the treatment of her disease. So not only she becomes independent, but she takes care of herself and her family in a large way. So therefore, that's what she used to do. In fact, I remember she used to treat patients with type 1 diabetes free of charge. She would give insulin from our stock from the hospital and see that the patients are followed up very carefully. And she always felt that no patient of diabetes, especially of type 1 variety, that comes to our clinic should not be deprived of the insulin therapy, which the patient deserves. So that's what she used to do. And that feeling, the compassion that she had for the patient is the most important thing. Unfortunately, we lost her early this year. She struggled quite hard, tried to give a brave front to the disease for 2 years. But unfortunately, despite of all our efforts, we could not succeed in giving benefit of that life to her. But then even at the end, when she was sure that her life is no more likely to exist, she told me that whatever my missions are there, please continue. See that whatever I left my wishes halfway through, see those things are done completely. And to the best of your ability and capacity, you see that the mission continues. I think those words are still ringing in my ears. And every time I think of her, these words came to my mind. And when Purvi said that we're going to have this meeting in her name as a tribute to her, I'm very happy. And wherever she is, she'll be definitely watching this CME, Purvi, and she'll be always be happy. And thanking you for having done so much for the treatment for the people of diabetes with women. With these words, I think I hand over back to you once again, thanking you immensely for considering to tribute her on behalf of this CME. Thank you once again.
Thank you, sir, for those very, very heart, I mean, they are very touching words. And we really hope, I know that she deeply admired Dr. Usha Shriram ma'am and always said that she is my mentor. And today for us to have her here with all of us and with all of you, and this encouragement that we receive from Dr. Banshi sir. He never looks at his schedule. If you ask him, can you make it? And the answer is always a yes, always. So it really means a lot to all of us. And on that note, I think let's just begin with our mission that we've undertaken. So I invite my co-chair, Dr. Rutul Goklani, and Dr. Abha Gupta, who's a very precious asset of the Diabetes and Women's Interest Group, to take this forward.
Thank you very much, Purvi ma'am. Thank you very much, everyone, for joining us here. And it is really an important webinar today. And when we are remembering our ma'am, Benny Neglur ma'am, I am really fond of her, those memories. When I first time when we talked and she was all mentioning about her passion for women and diabetes and what she used to work for, and that was the COVID time and first time I joined that her conference, which was actually online. And that time, I was given the topic was cardiovascular disease in post GDM. And today we are again talking about this all stuff, and really we all are missing her so much. Without wasting much time, I would say that our first speaker is Dr. Usha Sriram ma'am, and she's founder of Divas. She is a graduate from Madras Medical College, AB Internal Medicine, and AB Endocrinology, Diabetes and Metabolism. She is head of Department of Endocrinology, Diabetes and Metabolism, Voluntary Health Service of Chennai. She is president of Indian Society of Bone and Mineral Research. She has special interest in GDM, women's health, osteoporosis, preconception care, and medical ethics. And she is past president of ISBMR. And today, as she is going to talk mainly in menopause, MHT, and further. Over to you, Usha Sriram, ma'am.
Thank you, Rutul, for a very kind introduction. But before I begin to give my talk on menopause and metabolic health, I have to tell you, Benny was a very dear friend, a great colleague. And what I feel the most is I've lost a champion, a warrior in this, we need warriors for this women and diabetes initiative. And she was one of those. And we have lost her, but she's there in spirit with us. And I think that should also guide us towards doing, bigger and better things and more for the community. So, I thank Banshi and Amit and Purvi and everyone for this very kind invitation. I'll first try to, share my slides. Do you see it?
Yes, ma'am. Make
Yes.
it in
Slides?
full screen. Yeah, it is visible.
Yes, thank you. So the topic that has been given to me is the menopause and metabolic health. And I want to thank Amit for flagging this very important point that when we think of, or when we have been thinking of women's health, we've always thinking of through the reproductive lens only. So even if you go to conferences or anywhere, the topics are usually something to do with GDM, which is extremely important, but that's not all of it. There is so many other issues: cardiovascular health, metabolic health, osteoporosis, cancer screening, so many mental health, so many things. So this is really an expansion of that dialogue. Not only its reproductive health, but it also should include all aspects of women's health. So this is a very, very, very important slide, and I want to just show you something. The age at menopause has remained the same, somewhere between 47 and 53, on an average somewhere around 49, 50, since Manu Shastra days. We don't have time for me to go through those things, but it's been the same. Whereas female life expectancy has gone up tremendously when, from women living only into their 40s and 50s to all the way into the 90s now, so much so that women are spending half their life after the menopause. So it's so important for us to know what happens to women after the menopause. So having said that, that this happens somewhere around 47 to 53, and in Indian women, it seems to happen earlier, somewhere close to 47. There is this thing called as the menopause transition or perimenopause, and then this very, abrupt kind of finite thing that happens, and then the postmenopausal years. So this menopause transition can be up to 4 years, before the actual final menstrual period. And why this is important is women can have vasomotor symptoms and can also have changes in their metabolic health starting those few years before the menopause. So as physicians, and people of public health interest, we need to also focus on this phase of a woman's life, and try to get her into a healthy place before all of this starts. So otherwise, what happens, menopause is a natural, definite event that happens in women's life, inevitable. So we can get her into a healthy place before it starts. So transitioning from premenopause to postmenopause involves all of these things: hormonal changes, reproductive health changes, physical changes, body composition changes, CV risk changes. But today, I want to highlight that there are metabolic changes that are happening. And I've started changing instead of saying a life course approach, like a lifespan, we have to look at people as health span. So this is very important. Health risk changes, and a very, very brief, quick review: changes that happen to women's reproductive cycles as a normal part of reproductive aging. So when they approach their mid 40s to mid 50s, ovarian function decreases, major alterations to the established hypothalamic pituitary feedback. We know that the ovary stops making eggs, and then there is less decrease in estrogen, and there is increase in FSH, and you can see that from this. There's a natural decline of ovarian reserve, end of fertility, but also, while that is like almost comes down to nothing, and though there is a big decline of estrogen production, it's not like completely gone. Okay. So the consequences of this, typically we think in terms of the vasomotor symptoms like hot flashes and sweating and sleep troubles and menstrual problems and psychological symptoms. And then vaginal GU symptoms, vaginal atrophy, dyspareunia, urge and stress incontinence happens a few years later. And then, of course, all this osteoporosis and heart disease and Alzheimer's. But even here, we really are not mentioning the metabolic consequences. Let me show you. This is a fantastic slide that explains everything. So in the premenopausal years, the estrogen is high, FSH is low, AMH is normal or high. And then in the menopause transition and postmenopause, you can see the changes that have happened. And then consequentially, and also we must remember that menopause happens at an older age. So it's always a combination of aging and these changes across menopause that will increase the cardiometabolic risk: weight changes, fat mass changes, increase in visceral adiposity, upper body composition changes, insulin resistance, dyslipidemia, blood pressure changes, and the carotid intima-medial thickness and some vasomotor changes. And if you come on this side, you'll see things like fat-free mass is actually decreased, insulin secretion clearance, all these things. There are big changes all the way around: cardiac health changes, sleep health decreases. So what does all this lead to? You can see the hormones coming down, but can you see how the risk of diabetes and cardiovascular disease is going up? So this is something that we need to focus on when we are taking care of women, that in the perimenopause and postmenopausal years, big changes are happening to their body that's making them predisposed to these metabolic and cardiometabolic issues. What if she's already having diabetes? You can see that all of these will get amplified. And why this is so is because estrogen itself seems to be a key regulator of energy homeostasis and metabolic health. And I won't go into all the details. And if you can see here, due to the estrogen receptor signaling, there's big control of energy homeostasis and also a lot of peripheral effects on the liver and white adipose tissue, brown adipose tissue, skeletal muscle, and pancreatic beta cells. And we need to keep this in mind. I mean, could this be offering some therapeutic options in the future? So typically we attribute these symptoms to the menopause, especially hot flushes. So why is that significant in this conversation on metabolic health? I just want to tell you that the association between vasomotor symptoms and metabolic health in peri and postmenopausal women, and in this systematic review, and they were able to actually show that vasomotor symptoms in women during the menopause could be a biomarker of CVD risk. So we need to be listening to our women. Are they asking them, listening to them, are they having vasomotor symptoms? Really important to keep this in mind. So, and you can see here, coronary artery disease, stroke, and cardiovascular disease, all of these things are increasing, especially in women who are experiencing vasomotor symptoms. Now, why I want to say is, on the one side, the women who are experiencing all this need to tell their physician so they can also be screened for cardiometabolic health. And us as providers need to listen to them to know that these women may be at greater risk and not be dismissive about, this happens to a lot of women during the menopause. So quickly, I want to tell you, I mentioned earlier what estrogen does, but let me focus on what it does in terms of the metabolic health. On the adipocytes, it has an effect. On the pancreatic beta cells, it has an effect. Increased insulin gene expression, increased insulin secretion, without increasing the beta cell. And then in the gut microbiota, it has an effect. So you can imagine what happens when estrogen goes down. You're going to have the opposite of these effects. So what happens during the menopause and menopause transition, in this big study called as the SWAN, Study of Women's Health across the nation, lower estrogen concentrations resulted in a 47% higher risk of type 2 diabetes during the menopausal transition. So after 11 years of follow-up in this other study, the EPIC Interact showed that if a woman had menopause before the age of 40, there was an increased risk, a 32% greater risk. So this is another important clinical, pearl I want to pass on, which is when we take the history from women, we need to ask them about their reproductive health. We need to ask them about what happened during their pregnancies, because all the complications of pregnancy, they are all windows to future chronic disease, especially things like cardiometabolic health. So, so women with a reproductive lifespan less than 30 years had a higher risk of type 2 diabetes than in women who had the usual menopause at the usual age. And then menopause is associated with postprandial metabolism, metabolic health, and this is the Zoe Predict study, which showed that that women's sleep quality was poor, their glucose peak was higher, their postprandial and their glycemic variability was also abnormal in the postmenopausal years. What happens to the weight? Is it we always talk about menopause weight gain. Is it a myth or is it a reality? Unfortunately, I want to tell you it is a reality. The average weight gain is somewhere around 5 pounds, and it's more of a upper body obesity. It's usually associated with a metabolic syndrome, hot flashes. Again, this comes up, sleep deprivation, sedentary lifestyle, a decrease in muscle mass. Very, very important to keep in mind. And the other things that go on are total fat mass goes up, visceral abdominal fat goes up, increased ectopic fat storage in liver and skeletal muscle, and reduced peripheral fat, to keep in mind, and how this could promote poor cardiovascular health. What about the metabolic syndrome? the prevalence of the metabolic syndrome increases steeply after the menopause. Compared to 14 to 45% in women of reproductive age, it goes up double, 30 to 70% in women after the menopause. This is again very important to keep in mind. This absolutely lovely slide shows you the metabolic syndrome in premenopausal women. Now you add menopause to that. There is increasing androgen, decreasing SHBG, increasing bioactive androgens, the central adiposity. So everything, this becomes metabolic syndrome on steroids, so to speak. So an increased risk of the metabolic syndrome. And why is it important for us to focus on obesity, especially post-menopause? Is, obesity is associated with decreased brain volume, slows cognitive function. And in women with diabetes, there's an increased risk already of vascular dementia. And then if we add obesity to it, this could be again amplified. And brains of overweight and obese individuals appeared 8 and 16 years older, respectively. Now, what about cardiovascular disease? In this lovely slide from Nature, it shows you on the one hand, menopause and aging, physical inactivity, mood instability, sarcopenia, leading to obesity, and then indirect effects on cardiovascular risk factors, which I've already mentioned, including the dyslipidemia. And I want to point out here the dyslipidemia changes happen really early. Within 6 months, you start seeing the HDL going down, LDL going up, and a direct effect on the vasculature and activation of the renin-angiotensin, increase angiotensin 2, decrease nitric oxide synthase, and all of this leading to oxidative stress, atherosclerosis, and ischemic heart disease. Now, I showed you on this side the effect of the menopause on all of these, especially the lipids. And when you give hormone therapy, menopausal hormone therapy, what happens to that? For most parts, it seems to be positive in terms of total cholesterol coming down, LDL coming down, triglycerides may stay the same or may go up, and HDL going up. So it seems like a no-brainer, right? Premenopausal women have estrogen. Postmenopausal women don't have estrogen. So why not give the estrogen? Everything will be fine, right? Well, before we started thinking like that, these were the kind of treatments that were given to women during menopause. Everything from bloodletting to leeches to all kinds of potions and poultices and stuff that was given to them. And of course, most of the time they were thought to be hysterical, and they were given treatments for mental health issues and bovine urines. Everything was given. Thank God we are not in those Victorian days era now. And then became the hormone therapy. Unfortunately, hormone therapy has gone through its many phases, from being considered the fountain of youth to poison to, again, it became good medicine, and then it again became poison, because after the Women's Health Initiative was published, really what it showed was that premenopausal women plus estrogen is not, in postmenopausal women plus estrogen is not a premenopausal woman. So we now are limiting hormone therapy only to women with symptoms, and we take them through a short period of time treating their symptoms, keeping a close watch on them, of course. And most of the professional societies have said that hormone therapy really should not be considered for primary prevention or secondary prevention of cardiovascular disease. I think that has been partly because the WHI showed that there was an increased risk of cardiovascular disease. We can discuss the WHI in detail later, but just to give you the summary of that. So menopausal hormone therapy, super effective for symptoms, tailor it to the individual, should be used in the lowest effective dose. Annual consultation should be done, and safe for about 4 to 5 years. After that, the risk of breast cancer starts going up. And risk and benefits differ during the menopause transition compared with post-menopause. Obviously, a thorough evaluation of the woman has to be done, and it has to be very personalized, looking at what are the indications, are there any absolute contraindications, relative contraindications, age of the patient, years since menopause, is there an intact uterus, comorbidities, quality of life. All of this needs to be taken into account before prescribing HT. And then there are more questions: which estrogen, dose of estrogen, route of estrogen, how long are we going to give it, which progesterone, how to follow up. So suffice it to say, menopausal hormone therapy is not youth pill. It is a very nuanced it's a medication which has to be done in a very nuanced way. And really important to keep in mind that when you give it to women with diabetes, it can be given to women with diabetes. It improves actually glycemia and insulin resistance and other components of metabolic syndrome. However, we need to keep in mind that we are watching the triglycerides, and we want to absolutely make sure that they don't have any of the other contraindications. And we really are using it to treat symptoms and not to treat the cardiometabolic status. And many pharmacologic options are there, from hormone therapy to non-hormonal things like venlafaxine, and then things like gabapentin, pregabalin, depending on what should be used. Phytoestrogens and isoflavones and complementary. Safety and efficacy data are insufficient, so strong recommendation not to be using those agents. And please counsel all your patients to totally stay away from all of these kind of phytoestrogens, because we really do not know what effect it may have on the breast or other tissues of the body. So say no to these. I want to say, stop here. If I have a minute more, Purvi, can I speak for a minute more?
Of course.
Yes, ma'am. Please go ahead.
Okay. There are 2 or 3 specific things that I want to mention. One is women who have early menopause, premature ovarian insufficiency, and metabolic health. The risk of premature ovarian insufficiency is going up globally, and in India also in a big way. And it's been shown the association with menopause and CV risk and metabolic risk is more evident in women with premature ovarian failure. So we need to really ask women these questions about when their menopause happened. The second thing is the newest baby, which is MASLD, or non-alcoholic fatty liver. In this one, the odds ratio of women postmenopausally having this is higher. It's 2.37. Keep that in mind. And also, when you look at patients with NAFLD, if they are postmenopausal, the woman's similar risk of CVD, if you look here, as versus age-matched men. So obviously, clearly a higher risk for cardiovascular, even in premenopause, a higher risk of CVD. So something that was brought up today or in the earlier comments: premenopausal women with diabetes are at greater risk than even postmenopausal women in some ways. They just seem to be in a more pro-inflammatory state than even postmenopausal women. So we really need to give, really look at them very closely. And like I mentioned earlier, what is more important is to prescribe all of these things: healthy diet, regular exercise, positive attitude to life, engaging in hobby, house or community work, no smoking, alcohol. And when I say vitamins and antioxidants, typically from food sources and not supplements. And we want to make sure that they don't have vitamin D deficiency or a B12 deficiency, and you want to supplement it. And hormone therapy only where indicated. So if women are put on this, and screening, of course, for cardiometabolic risk, if they are put on this kind of a program well ahead of time, then they can face the perimenopause and menopause and what is going to happen. Definitely, it's going to happen. What is going to happen subsequently in a much better, healthier state than starting out with already with challenges. Thank you so much for your patient listening.
Thank you very much, ma'am, for wonderful, wonderful talk. And we really enjoyed and how menopause and post-menopausal healthy lifestyle is important, and even before that it is more important, and how diabetes contributes to it. So we also want to know, what you talked about is pre-menopausal lady with diabetes, but what about post-menopausal lady with diabetes? How much the risk increases for other diseases, especially metabolic disorders and cardiovascular diseases?
You want me to answer it now?
Yes, yes, ma'am.
Sure. So clearly everything is going to be, amplified. What I meant was, see, typically premenopausal women, I don't want to preempt Annabelle, but premenopausal women are protected from cardiovascular disease, right? For at least 10 years. They have a 10-year advantage over men. The moment they develop diabetes, whatever age that is, that advantage is gone, is wiped out. Not only that, there seems to be just a more aggressive pro-inflammatory state in these women. And also, then there's this other issue. Typically, we don't go around screening young women, right, for cardiometabolic health. So they have diabetes, but we are not taking this into account that though they are premenopausal, they are at greater risk for cardiovascular disease. So that is for premenopausal. But when they come into postmenopausal years, everything is added on. Their lipids are worse, their weight goes up, they have upper body obesity, their cardiometabolic risk profile becomes so much worse. So definitely they are at a worse shape than women without diabetes.
And last question or a comment, that what is the simplest way to screen them for cardiovascular disease in that younger women, because it becomes really difficult to ask them to go for like extensive screening, but what is the simplest way you would suggest?
Well, this very simple way is to look at risk factors. Screen them for lipids, screen them, look for hypertension, look at their look for obesity, waist circumference. None of us measure waist circumference. Measure waist circumference. So those are and of course definitely their glycemic status. So these are the cardiovascular risk things, and then take a history. For example, if you take a history, so the guidelines tell us to use SGLT2 or GLP only in people who have ASCVD or heart failure or CKD, right? Typically, as a initial treatment. And when you take a woman and she doesn't have a history of any of this, we may not be going in that direction. Whereas if we took a history and things like carotid intima medial thickness, or coronary calcium score is a good surrogate. Not carotid intima thickness, but coronary calcium is a good score. The ADA says do not test people who are asymptomatic, but then that's a matter of, you need to take the history on how active they are. Many people are not active, so you won't know anything about their symptoms. So it's a lot of history taking also. I think Annabelle is a global expert on this, and we'll ask her also. Yeah. And before we close, if there is one individual who has single-handedly motivated me to take up gender medicine, and is Annabelle Workman.
Wow, great, great. We have her here.
We have
So,
our mentor's mentor and mentor's mentor's mentor.
wow. So now I would request our co-chair, Dr. Abha Gupta, to take over and take the session ahead.
Thank you, Dr. Rotan. Our next speaker is Dr. Meena Chhabra, ma'am. She's going to speak on SGLT2 inhibitors and GLP-1 agonist. We have heard many lectures on these two class of drugs. But today, Dr. Meena is going to speak on these two drugs with special reference to women. I think all of us know very well Dr. Meena Chhabra. She's a very senior consultant and a diabetologist at Shri Gangaram Hospital, New Delhi. She was chairman RSTI Delhi chapter between 2020 and 2023. She's presently chairman Innovative Physician Forum, and has received many awards as well. RSTI Award for the Excellence in Diabetes Care in 2019, Women Diabetologist of the Year in 2023, and also an award from the DMA in 2018 for the Distinguished Service. She's not only an expert on diabetes, but also expert in many other fields in the medical sciences. And with these words, I request Dr. Meena Chhabra, ma'am, to please deliver her lecture.
Thank you so much, Dr. Abha, for those kind words. And thank you, Dr. Usha Sriram. But before we start, Dr. Usha, are you still logged in?
Yeah.
So, Dr. Usha, when you say preconception, what is the period you are referring to? That's it, because my talk will mention preconception several times.
Preconception. Okay.
Yeah,
Preconception is ideally 3 to 6 months before the woman gets pregnant. But depending on what we are trying to change in the preconception years, if it is something like, for example, weight, it may have to be a longer period. So the Lancet Commission on this actually says it could be something as little as few weeks before, things like quitting certain things like alcohol and all that, to few months, to definitely you want to start folic acid at least a month before, to few years if you want to put in big changes, but on an average 3 to 6 months.
Okay, thank you so much. So I'll go on to share my slides. Good evening, everybody, and it's an honor for me to be a part of this forum, especially when we are honoring the memory of a very dear friend, Dr. Benny. Are my slides visible, Purvi?
No, not yet, ma'am.
It's wrong then. So here they are. No?
Yogesh, can you help?
Yeah. Can you see them now? No?
No, ma'am.
What's happening? So, okay. Yogesh, can you help? I have them right here.
Yes, ma'am. Just a moment.
So can you see? I have my slides right here on this logo PowerPoint here. What will not able to share? Share and
Yes, ma'am. Now it is visible.
Yes.
yeah. Okay. So
Just make it in full screen mode, ma'am.
your screen sharing, yes. Okay. And slideshow from the beginning. Good evening, doctors. I'm so sorry. So my talk today will focus on the role of GLP-1RA and SGLT2 inhibitors in women with type 2 diabetes. I find this topic very interesting, and Dr. Usha stole my words when we said that the guidelines don't mention several things that we will be discussing in my talk today. So GLP-1 receptor agonist and sodium glucose co-transporter inhibitors has transformed type 2 diabetes management by offering cardiovascular and metabolic benefits beyond glycemic control. Now, what is the advantage in women? These therapies address sex-specific risks, including hormonal fluctuations, polycystic ovarian syndrome, and our guidelines don't mention that. Of course, they address cardiovascular complications like they would do in men, but they also address cardiovascular complications in women who are premenopausal and have a high cardiovascular risk. So briefly, because we should know briefly about the GLP-1, what do they do? Act on the pancreatic beta cells, increasing insulin secretion, act on the alpha cells, decreasing glucagon. So they stimulate glucose-dependent insulin secretion. Now they slow gastric emptying. So they promote satiety and reduce food intake. They also have a central effect, those which cross the blood-brain barrier. They reduce hunger and reduce caloric consumption. Of course, they have cardiovascular effects, which we will be talking about. Now, the SGLT2 inhibitors, they increase urinary glucose excretion. For every 1 gram of glucose that is lost in the urine, 4 calories are lost. So when you give an SGLT2 inhibitor, roughly 70 to 80 grams of glucose is lost in the urine. So the patient has a negative calorie balance where he loses about 280, he or she loses 280 calories in the urine. Of course, they have very good metabolic effects, reduce blood glucose, they reduce blood pressure, and they promote weight loss, but modest weight loss. So how are these two drugs different? In my mind, GLP-1RA address appetite, promotes satiety, while the SGLT2 inhibitors do not address satiety. They just push the glucose in the urine and create a negative balance. So their indications may be different, but we have various studies and trials where they have been used together. Now, when I was going through the trials and the meta-analysis of various SGLT2 inhibitor trials and the various GLP-1RA trials, I've noticed that the ratio of the men and the women was not similar. There were much less women in the trials than men. And the other thing is that premenopausal women were less in the trials, even lesser. Reason being that most trials had high-risk patients and they were usually postmenopausal. Now, what do GLP-1RAs do on MACE reduction? This is meta-analysis of more than 13,000 women, 17% lower risk of major adverse cardiovascular events compared to placebo. Then consistent reduction in stroke and myocardial infarction in women with established cardiovascular disease. So when I say established cardiovascular disease, I mean a patient who's already had a stent or a PTCA or a bypass surgery, patient who's had history of a transient ischemic attack. And Dr. Usha Sriram said, we also have our antenna up if we think of high-risk cardiovascular disease. For example, she mentioned doing the carotid intima media thickness, doing the coronary calcium scores. Also, simple tests like ankle brachial index can tell us that the patient has a high risk of atherosclerosis. Now, one interesting thing is that GLP-1RAs reduce systemic inflammation. They decrease markers of inflammation and platelet activation. They decrease thrombotic risk factors, which may contribute to cardiovascular events in women. This is a very important effect of the GLP-1. What are the benefits of GLP-1RA in women? They also, on the kidney, they also reduce albuminuria in women with diabetic kidney disease, although SGLT2 inhibitors have been studied more, and slow decline in the EGFR and the anti-inflammatory effect. What about the cardiovascular benefits of SGLT2? There's a reduction in heart failure by 31%. There's a small 3 millimeter of mercury reduction in systolic pressure and 2 millimeter mercury reduction in diastolic pressure. And there's a reduction in cardiovascular death, mainly driven by reduction in heart failure by about 20%. Now, renal benefits of SGLT2 in all the spectrum. So in early CKD, when there's proteinuria, they prevent progression of micro to macroproteinuria and macroproteinuria to CKD. And then even in reduced risk of EGFR decline by 30 to 40%. And advanced CKD also, we can use them, of course, when the EGFR is less than 45 and we are using an SGLT2 inhibitor. It is mainly for glycemic, not for glycemic benefits, but for benefits for on heart failure and for benefits on progression of chronic kidney disease. So weight managements, definitely the mechanism is different than the GLP-1RA, which I mentioned. So they just cause a caloric deficit. Now, what if we use both the therapies? We combine both. So there's a 3 to 5 kg additional weight loss because their mechanisms are different. Remember the SGLT2 inhibitors, when they push the glucose in the urine, the body perceives as loss of glucose when there's glucosuria, and there is increase in glucagon, which increases the breakdown of glycogen to glucose and also promotes gluconeogenesis. While the GLP-1RAs do not increase the glucagon, rather decrease it. So the increased insulin, decreased glucagon, hypoglucagonemia. So they're complementary mechanism of action. And when used together, we get additional weight loss through two different mechanisms. Now, this is an important slide. Other than what we were talking about, which we've heard several times about addressing maize and heart failure, we're talking about PCOS and reproductive health. What do the GLP-1 RAs do here? So GLP-1 RAs help restore ovulation cycle in women with PCOD by improving insulin sensitivity. And we all know when there's hyperinsulinemia, insulin increases androgen production by the liver. So once the GLP-1 RAs help in decreasing insulin resistance, in helping the patient reduce weight, there is improved insulin sensitivity at the level of the liver, the muscle, and the adipose tissue. There is regular ovulation. This leads to a more predictable menstrual cycle and improved fertility outcomes. Now, hormonal balance, these medications help reduce androgen, I told you. And because there is a lower testosterone now, there is improvement in hirsutism, acne, and male pattern hair loss. So for women with PCOS seeking pregnancy, GLP-1 RAs may improve fertility by restoring ovulation, but they're not approved during pregnancy. So I'll tell you here, I'll take 1 minute to explain that during the preconception, which may extend, Dr. Usha said it very nicely, that if a couple comes to you when they're planning a pregnancy and the woman is a known case of type 2 diabetes with obesity and complains of difficulty in conception, and according to the Rotterdam's criteria has PCOD, what we can advise is give her time. We call it the preconception period. And in real world, what we do is give her GLP-1 RA, whether oral or injectable, for 6 months. That is when we tell the couple to use a barrier contraceptive and no other oral contraceptive, but a barrier contraceptive. And in 6 months, she loses about 5 to 10% of her weight. And then we tell her to stop the GLP-1 RA and then plan conception. And this is an important message from here, that you could actually start at 6 months to 8 months. So preconception is extended in obese type 2 diabetic women who are planning a pregnancy and are facing a difficulty. Now, what are the various considerations? I've talked about preconception planning. We should discuss it. And we should not give them GLP-1 RA or SGLT2 inhibitors if the patient does not want to wait, because both of them are not approved for if the patient becomes pregnant. And alternative therapies, of course, insulin and metformin. And we should definitely encourage the patient not to get pregnant when they are on these drugs. And unfortunately, I put a patient on Mounjaro and they forgot to use a barrier contraceptive, and now she's pregnant. And we don't know, and since it's a very difficult pregnancy after 10 to 12 years of marriage, they're not ready for a medical termination also. So we have to be very careful. Use it in preconception, get the desired results of a weight loss, better ovulation, for patient and the fertility issues are addressed, and then go ahead with pregnancy after stopping the medication, both of them. So menopausal considerations, ma'am's taken up, but I'll tell you, GLP-1 RA offer cardiovascular protection. Then because menopause triggers metabolic changes, there's increase in insulin resistance, visceral adiposity, which ma'am discussed. GLP-1 RA are a very good choice. Here, bone health is important, osteoporosis. The SGLT2 inhibitors definitely impact bone density negatively. We saw in the Canvas trial that there was increased incidence of fractures with the canagliflozin. Of course, real world evidence did not prove that, but definitely GLP-1 RAs appear neutral or potentially beneficial for bone health. Now, again, what about SGLT2 inhibitors? There are bone health concerns in postmenopausal women. Otherwise, there's one more thing that can happen, that osmotic diuresis contributes to blood pressure reduction in postmenopausal women, and therefore it can address the increased hypertension risk that postmenopausal women have. So they are definitely beneficial with both diabetes and hypertension. We can use the SGLT2 inhibitors in these women. And coming to safety profile, we know SGLT2 inhibitors can increase genital infections. They can increase the risk of UTIs, and DK risk, of course, is less than 1%. But definitely women have a 3.3 times higher relative risk of genital mycotic infections with SGLT2. Now I'll take a minute. we did a real world trial. We were about 10 to 12 doctors, called the Genesis trial, and we found that the genital tract infection in women was about 8 to 10%. In my practice, it is slightly more, 10 to 12%. And in men, uncircumcised men, circumcised men did not develop balanitis or balanoposthitis. It was much lower. So now coming back, we can use a combination therapy. When we use a combination, we not just reduce major adverse cardiovascular events, but we also decrease heart failure hospitalization. We help the patient to manage weight because appetite is addressed. There is satiety because it not only promotes the gastric emptying is delayed, so it promotes satiety, also acts on the central hypothalamic center. So combination therapy has both renal benefits. And when to choose SGLT2, we all know heart failure, first choice for women at risk for heart failure. Chronic kidney disease, again, weight management, modest weight reduction with SGLT2 inhibitors, and not as much we get with GLP-1RA. When to choose the GLP-1RAs in women, atherosclerotic cardiovascular disease, their first choice for women, both with high risk ASCVD and established ASCVD. So when I say high risk ASCVD, you should always take the history of sudden death or myocardial infarct in a first degree relative, and a first degree relative is a parent or a sibling or your children. So if there's a history of sudden death, age less than 60, we should actually use, these drugs more often and address the ASCVD risk, because it's, of course, smoking has to be addressed. Women who have significant obesity and need substantial weight loss, we should be putting the patient on GLP-1RAs. Again, I mentioned PCOS, beneficial for women with insulin resistance and PCOS, and beneficial for women who are married with type 2 diabetes, PCOS, and have been going to infertility clinics. If you help them lose weight, insulin sensitivity improves, hyperandrogenemia decreases, ovulation improves, and the patient might respond better to fertility treatments. So emerging research, fatty liver disease, we know that reduce liver fat, decrease hepatic fat content, decrease inflammation, reduction in liver enzymes and inflammatory markers. This is, fatty liver is more common, and now we are seeing more and more fatty liver because obesity is increasing in the younger population. So these drugs help, SGLT2 inhibitors help in addressing fatty livers. Now, these are case studies. These are interesting case studies. This is a postmenopausal woman with established cardiovascular disease. She was only on metformin and her HbA1c was 8.2. What would you like to do? You can either add a GLP-1RA, dulaglutide once a week. You could also add liraglutide in the now I'm using more and more liraglutide because it is off patent and it's cheaper. So we have several GLP-1RAs in our armamentarium. You could use dulaglutide once a week. You could use liraglutide in the dose of 0.6, build up the dose to 1.2 and then to 1.8, because we don't have the 3 milligram dose, which is approved for obesity in India. You could use that to address obesity and to address in the postmenopause, in this woman, she has a high risk of cardiovascular disease. So you see, you could also use oral semaglutide in this patient. So for postmenopausal women with established ASCVD, GLP-1RAs offer comprehensive benefits. Now, this is another case study. This is a woman with heart failure and renal impairment. She was diabetic for 8 years, hospitalized for heart failure with preserved ejection fraction. So adding SGLT2 inhibitors for her heart failure. And what were the outcomes? HbA1c was reduced. We could also add the GLP-1RA because the GLP-1RAs can be used even in chronic kidney disease with a very low GFR. Provided the patient can tolerate. Some of them may have nausea, vomiting, and may not be able to tolerate the GLP-1RA. So again, SGLT2 inhibitors are a good choice. We could also use a combination. This is a woman with PCOS and obesity. She's only a 32-year-old woman with recently diagnosed type 2 diabetes. She has a long-standing polycystic ovarian disease, irregular menstrual cycles, and class 2 obesity. HbA1c is 8.5, not currently on diabetes medication. She desires improved metabolic health, but also potential pregnancy in the next 1 to 2 years. So for her preconception can be as long as 1 year or 2 years. So we started her on metformin for its benefits on both diabetes and PCOS, but we added a GLP-1RA And we gave her a clear plan that you cannot become pregnant on a GLP-1 RA. We told her to discontinue. We should tell her to discontinue in 3 to 6 months before attempting. So it's not 3, but I gave her 6 months because she will lose about 10% of her weight with GLP-1, expecting to lose with oral semaglutide 5 to 10% of her weight. And then of course, contraception, I told you, counseling was provided. After 6 months, her HbA1c was reduced to 6.5. There was a weight loss of about 8.3 kg. Her menstrual cycles became regular. Hirsutism and acne showed modest improvement because of the reduction in hyperandrogenemia. Patient reported a high satisfaction with treatment in spite of initial nausea, and we could tide over that period with telling her to eat small meals. So for reproductive age women with PCOS and type 2 diabetes, GLP-1 RAs can address both effectively. Of course, again, I repeat, pregnancy planning, preconception planning, and contraception are essential. We have, once the desired weight is lost and ovulation becomes regular, we could stop the GLP-1 RA and put her on metformin, and then she can plan a pregnancy. So this, I would like to take this slide because once we're using in women, we have to remember to tell her that if she develops a genital tract infection, she has to report to the doctor. Now, whenever I'm in a meeting, I always say that the risk of GTI is 10 to 12%, or maybe 12 to 15%. But my male diabetologist and endocrinologist refuse to believe it. And probably it is because when a female patient develops genital tract infection, she doesn't go back to the male diabetologist, but ends up going to the gynecologist. So, and they come back to us as female diabetologists, and we know it is the offending drug is the SGLT2 inhibitors. So again, it's a humble request to write down that there is a risk of genital infection, to talk about genital hygiene, and if the patient develops genital tract infection, to report to the doctor. Very mild infections can be easily treated with the local application of antifungal. You can try clotrimazole 1% or something, but if it's more, you may need oral antifungal, but we can restart the SGLT2 inhibitor after this episode of GTI has been treated. And if she, so this is what, but for GLP-1 RA, what happens when there is an acute illness? So even SGLT2, if the patient has fever, viral fevers, she has dehydration, has diarrhea, we should temporarily discontinue to prevent euglycemic decay, which is a possibility if the patient is dehydrated, not drinking water, and has very high fever. Then GLP-1 RA, we should consider oral intake. If the oral intake is poor, then you can skip the dose. If you're giving weekly GLP-1 RA, you can skip the dose for 3 to 4 days and then give the dose. And if you're giving oral semaglutide, you should definitely consider not giving the dose for a few days if there are significant GI symptoms. So during acute illness, all women, to prevent complications, should be taught about the sick day rules when they are on a GLP-1 RA or an SGLT2 inhibitor. Then this is about perioperative management. Yes, this is again important in a woman undergoing surgery. Now, 1 to 3 days before surgery, continue weekly formulations of GLP-1 RA if you are giving once a week. If you're giving oral semaglutide, we actually stop the semaglutide 1 to 2 days before surgery because they delay, all the GLP-1 RAs delay gastric emptying, and this may have an effect on anesthesia. So ideally, we should stop 1 week before we actually plan for surgery. But SGLT2, you can discontinue 24 to 72 hours before procedure, depending on the agent that you are using. But you should continue to monitor glucose and ketones. And once the patient, after surgery, post-op period, resumes eating, SGLT2 inhibitors can be started if the renal function becomes stable, and they can resume. But post-op period, I don't give the oral GLP-1 RA and give only insulins. And once the patient goes back after surgery and is stable, we restart the GLP-1 RA. Now, so again, I'll sum up. PCOS and obesity, GLP-1 RA will help in weight loss, will help in ovulation because it decreases hyperandrogenemia, will decrease weight, increase insulin sensitivity. SGLT2 inhibitors, modest weight loss, not as much as the oral GLP-1 RA or the injectable GLP-1 RAs. They don't have much effect directly on ovulation, but because they help in weight loss, there may be an indirect effect because of reduction in weight and reduction in insulin resistance. Now, women of reproductive age, preconception, again, very important. We've discussed this. Effective for obesity and PCOS, you can use this, not avoid if planning pregnancy, but tell the patient to not plan a pregnancy when they are on a GLP-1RA. SGLT2, not standard for PCOS. We don't use it. It's contraindicated in pregnancy. And pre-pregnancy or during the preconception, you can give the SGLT2 inhibitors, but 8 weeks before planning a pregnancy, you should stop the SGLT2 inhibitor, limited human safety data during pregnancy. So GLP-1RA, unknown placental transfer, not recommended, ADA 2025. SGLT2 inhibitors crosses the placenta in animals, contraindicated due to fetal risks. Now, lactation, GLP-1RA secreted in animal milk, avoid during breastfeeding. SGLT2 inhibitors detected in milk, again, unsafe for neonates, so you should stop. And I think during postpartum and lactation, we don't give these 2 drugs, not even DPP-4 inhibitors, and we mainly give metformin and insulin. In postmenopausal women, GLP-1RA weight loss may support bone health, but SGLT2 inhibitors, beneficial on the cardiovascular health, beneficial for heart failure, beneficial for progression of chronic kidney disease, but watch for genitourinary infections. And of course, postmenopausal age in a diabetic patient is a window for cardiovascular protection. So all our women type 2 diabetics who are postmenopausal have obesity and other risk factors like family history of heart disease, smoking, history of GDM, you've done the ankle brachial index and you've seen peripheral vascular disease, you've done the carotid intermedia thickness. All these risk factors are present. It's a window of opportunity to protect the patient from cardiovascular disease, and the patient should be on a combination of GLP-1RA, whether oral or injectable, whether weekly or daily, and SGLT2 inhibitors. So what are the risks? GLP-1RA GI side effects. We know that nausea, vomiting, we can tide over the period, but there are a few patients who cannot tolerate the nausea, vomiting, and we may have to stop. And of course, they cause appetite suppression, which is a good effect because foodies, they can't stop eating. SGLT2, we know, UTI, genital infections. Then, so to summarize, I've talked about the scale PCOS 2022. Liraglutide improved ovulation. This was studied and it decreased hyperandrogenemia. In the declared TIMI, the women subgroup was analyzed, and it was found that there were cardiovascular benefits on women, particularly women with preserved ejection fraction. And again, women with preserved ejection fraction heart failure are missed because A, they are obese, we can't hear the crepitations. B, echo windows are poor, we can't pick up. If you don't do the NT-proBNP, then we sometimes miss heart failure in women because they don't do any exercise, like Dr. Usha said. So when they don't exercise, they don't feel breathless, and we might miss this. One thing I failed to mention, sorry, I didn't mention, is OSA. Yes, obstructive sleep apnea improves when you give GLP-1RA and SGLT2 inhibitors because you are addressing the weight. Once the weight decreases, OSA decreases. Then if you talk about the DAPA-CKD and the EMPA-Kidney trial, equal renal benefits in women. So women were equally benefited by the use of SGLT2 inhibitors. Here, I would like to mention the Canvas study where there was increase in amputations and osteoporosis, but real world evidence did not, actually support that. So final takeaway message from me is use GLP-1RA for obese PCOS, but stop before conception. Use it, takes help to bring down the HbA1c, to decrease the appetite, to help patient lose weight, better ovulation, and maybe they don't need, IVFs. Avoid both drug classes in pregnancy, avoid both drug classes during lactation. In postmenopausal women, use SGLT2 inhibitors for heart failure, for CKD, use GLP-1RA for weight, for metabolic benefits on established ASCVD. Thank you so much.
Thank you, Dr. Meena, for explaining so well the specific indications, advantages, safety profile of these 2 drugs in special reference to diabetic women. I think she has touched every possible field, be it preconceptional period, pregnancy, lactation, non-pregnant premenopausal women, post-menopausal women, women undergoing surgery. I think every field she has touched and explained very well. Thank you, Meena ma'am, once again. And if any question from the audience, they can ask.
We'll not take the question as, ma'am, we are having panel discussion only. We'll be discussing those questions in panel discussion only. So we are really lucky to have Dr. Annabelle Wogman. and she is the face of Go Red Women. She's a prominent figure in cardiology who has been a leader in the American Heart Association's Go Red for Women campaign, and she is recognized for her advocacy and work in promoting women's heart health, particularly through the Rush Heart Center for Women, and where she served as medical director for 20 years. So we are lucky to have her here. And we request Dr. Meena Chhabra ma'am and Dr. Usha ma'am to be present in our panel discussion here. And I'd request our co-chair, Dr. Abad, to introduce our other panelists as well.
Thank you, Dr. Ruddle. The topic of the panel discussion is women, metabolism and diabetes, bridging gaps and advancing care. And we have very eminent panelists for discussing this topic, Dr. Bansi Saboo sir, Dr. Lotika Purohit, Dr. Dhruvi, Dr. Meena ma'am, and Dr. Usha ma'am. As far as Dr. Bansi Saboo sir is concerned, I think though it's my privilege to introduce Dr. Bansi, but in fact, he doesn't need any introduction. And he has so many credentials in his bag that it requires another webinar to tell all these credentials. But in short, Dr. Bansi Saboo sir is Chairman-elect, IDF Southeast Asia, Vice President, Diabetes in Asia Study Group, Secretary, Diabetes India, Indian Academy of Diabetes, past President, RSSDI, AIAARO, has many fellowships in his bag, American College of Endocrinology, Fellowship of American College of Physicians, International College of Nutrition, Royal College of Physicians, and MNA MS. He's expert of RSDI guidelines for management of diabetes. And he was awarded by ACE as a global clinician of the year.
Elder brother of Purvi.
Okay, thank you, sir. Thank you. Our next panelist is Dr. Lotika. Just a minute.
Lotika will not say I am elder sister, you know. She will say I am younger to Purvi. So I am younger sister.
Elder sister of Dr. Bansi. Dr. Lotika Purohit is Director, Diabetes Care Center at Mumbai and partner, Sugar Doctor Medicine LLP. She has leadership roles as a chairperson of RSDI Maharashtra chapter 2024 to 2025, and also she has published many papers in the national and the international journals. She was a speaker and chairperson at numerous local, regional, national, and international conferences. Our next panelist is Dr. Dhruvi Hasnani, beautiful diabetologist, renowned personality of Ahmedabad. She is fellow of American College of Physicians.
You are beautiful. We are ugly also.
Young, beautiful diabetologist. She is HOD at Clinical Research, RIMS, Ahmedabad, and treasurer of RSDI Gujarat chapter. She is winner of Torrent Young Scholar Award for Diabetes. And she is a speaker at numerous national, international, regional conferences. And she has also published many papers in national, international journals and investigator for many clinical trials. And the moderator of this panel discussion is Dr. Manoj Chawla, sir. He also doesn't need any introduction. Dr. Manoj Chawla.
He's handsome.
Thank you, Dr. Abad. I'm afraid before you call me brother or sister of Purvi, I think we will move on here and
but at least tell most handsome and young
yeah, handsome.
Yes, handsome and young.
Because he's constantly worried because you told Dhruvi is a young and beautiful.
Thank you, Abba, ma'am. Thank you. I'll take it as a
Dhruvi was young when she got this young award from Torrent before 20 years.
What? Bansi, she's only 20 years old. Don't say that.
Thank you, Meena. I'm only 20.
Okay, as the
I
moderator,
think
let me get some
So,
order
so
in the house.
before
over
Dr.
to Dr. Manoj
Annabelle
Chawla,
starts
sir.
speaking, this is the way we conduct panel
So
discussions.
Manoj is now
Yeah,
just tuck.
So
Let us
so
start.
I hand over the mic to Dr. Manoj Chawla, sir, a handsome, smart diabetologist of Mumbai, known to everyone.
Thank you.
It is
Thank you,
very
Dr. Abha. And
in the Diabetes India scheme of things, he's been the organizing chair and scientific chair for Diabetes India for the last 2 years. And for 2026,
This year he's organizing secretary.
secretary.
Yes.
He has to work more now.
right. Thanks, Purvi. And once again, let's remember Dr. Benny Neglur, in whose memorial we are all here this day today, and talking about women and women's health. And we are privileged to have Dr. Annabelle amongst us, along with Dr. Usha Sriram, Meena, and Banshi, and all of you panelists. So let me start shooting, and I can see that on the hour we're running a little late. So I will be shooting questions to each of you and would request crisp answers for the same. And as all the introductions were done as young and beautiful and whatever, let me start shooting the first question to Dr. Annabelle. Dr. Annabelle, from cardiovascular health point of view, what is young and beautiful? Who would you consider from cardiovascular health point of view really beautiful, healthy, and young?
Well, I can tell you, I have some beautiful 90-year-old ladies in my office. So it's not an age, but it's a matter of being, whether they're beautiful or not. So we see patients anywhere from 18 years old to 100 years old. My oldest patient was 101-year-old when she passed away. So I have taken care of thousands of women that are young and beautiful, no matter how old they are. And they unfortunately have a variety of cardiovascular disease. And I pay very particular attention to my women with diabetes because they are at the highest risk, higher than men's risk. When it comes to cardiovascular events. So I do take very particular aggressive approach to those women.
Thank you. So taking off from what you said, I'm taking the question to Dr. Usha Sriram. So is there under recognition? So I think everybody's screaming that, but would you say that there is under recognition of cardiovascular risk in diabetic women, Dr. Usha Sriram? And what would be the culturally sensitive approaches to promoting the lifestyle change in women who are either with diabetes, metabolic syndrome, or at risk of diabetes? So I'm putting these two questions into one for you, Dr. Sriram.
Sure. So the short answer to the first one is yes, there is under recognition of cardiovascular risk, partly, many reasons, starting with heart disease is still considered a man's disease. So, women are not in the radar of most practicing people, and also the women themselves. Second thing is, especially in women with diabetes, there are a lot of atypical presentations. So it may not be recognized easily for that. And of course, the age old, not including enough women in trials and not publishing sex segregated data, and all of those things are also contributing in a way. But really what it is that we are not looking into the traditional and non-traditional risk factors that happen to women that increase risk for cardiovascular disease. The traditional risk factors like diabetes and hypertension, dyslipidemia and obesity. But then women have non-traditional risk factors like gestational diabetes or preeclampsia, gestational hypertension, miscarriages, PCOS, GDM, and autoimmune disorders, domestic violence. Many things like this actually set women up for increased risk for heart disease. So unless we take a detailed history and know enough about our patient, we're not going to risk stratify them as high risk. So clearly, women and heart disease, we have a long way to go. And here I have to tell, I mentioned this before, but Annabelle hadn't joined at that time. She has single-handedly done so much for women's heart health. I think, we all owe a big thank you to Annabelle. Thank you, Annabelle. And second thing is culturally appropriate thing. We again comes from good history taking, talking to the patient about family dynamics, which is very important. Hierarchy. Do they get? Do they have the agency to buy the food that they need? See, easy for us to tell them, eat this, don't eat that, do this, go for a walk, sleep so much. All of those things, but they may not be able to do any of that, not have the agency for that. So unless we get into gain insight into what people, the women, what is their place in the whole family dynamics and what can they do and not do. So culturally, we need to take into account all of those things. And there are some things that happen in the family that they may not, they may have to eat last. They may not eat what they have to eat. They may not be able to go out and exercise. So we have to factor all of that in before and prescribe the right approach. So cultural sensitivity, very important.
But is that more in India, Dr. Sriram, or you see that in different parts of the world in terms of women placing the family much ahead of them and sacrificing their needs?
No, women prioritizing the family and deprioritizing themselves is in our DNA. That's a universal thing. That is a different thing. I'm talking about the socio-cultural context and fabric. And that is more in South Asian and Asian countries to an extent. And obviously where women are more empowered, in countries where more education, more empowerment, they're going to have more agency to do the things that they want to do.
Thank you. Wonderful. So I think the next question to Banshi. Banshi, is it time when we are talking about and being aware now about the cardiovascular health link with people with diabetes and especially women? Are we not focusing enough beyond glycemic control? You think lipid and blood pressure management needs to be more reinforced, especially for women with diabetes?
So I fully agree with you, Manoj, but I will take slightly more time. One more reason is for them is their primary care physician is not the primary care general practitioner or a physician. For women, most of the time, their gynecologist and their OBGY become friends because over a period of time, 20 years and 30 years, they become more close to them. And most of the awareness program are related to the cancer. It is related to HPV vaccine had come and suddenly they talk about all the CA cervix and the CA breast examination and all those things keeps on doing. I know because from the Rajpath Club where I'm the board of director, many times they do an afternoon program, but it is all related to their and I talked to them multiple times that let us talk about diabetes in women, let us talk about the cardiovascular health. Now, slightly they started talking about the osteoporosis part. And whenever it comes about the lipid and blood pressure control, even the sugar also and the heart disease, when they go to their primary care, which is their gynecologist, is not a GP or a physician, and they try to teach them more about the CA cervix or the postmenopausal, how they should take care of their emotional health, and then related to their CA breast, how it is to be self-examination, all those things. And the aggressive management of blood pressure, aggressive control of the lipids becomes, the side part of it. And they don't take about it. Neither many of our patients, they don't take flu vaccine when we talk to them about the pneumococcal vaccination, when we talk about multiple things, and they just say that it is not required because their doctor is saying that it is not a major challenge. Major challenge is all those things which are more commonly happening to these people. So I think we should also try to educate here our gynec friends, our OBGY colleagues, who are most of the time, maybe even themselves are also female. So we should tell them that this is also a major challenge for you. Diabetes and cardiovascular health, diabetes and hypertension and lipids control in the female is as important as we do it for male. There is no separate guideline that they should be as aggressive. And when they go back to their doctor, don't tell that 130 LDL cholesterol is sufficient. You need not to check your cholesterol again and again. You don't require a lipid lowering agent, or you don't need to get your lipids less than 100 or less than 70 as we ask for them. Same issue with the blood pressure also. So I strongly recommend that we should involve gynecologists and the Foxy and all of them for related to talk about the diabetes and CVD and all this thing. Usha Shriram have a very good connection with them, that inviting them for diabetes and pregnancy. But I think this diabetes and cardiovascular health also we can talk to our gynec colleagues, because they are the primary care physicians for most of the females, and they also need themselves, because many gynecologists are also coming and getting admitted for themselves for that, and they never took the treatment for neither for sugar or aggressive lipid management.
Can I say something, Dr. Manoj?
Yes.
So Dr. Usha and me, there was a very nice term called bikini medicine. Bikini medicine means that myopic, so Dr. Usha is smiling. Bikini medicine means that the myopic view that women's health only matters in the bikini area. So they focus on the breast and they focus on the vaginal health, cervical cancer, all that. And
but behind breast, there is a heart, at least. So they should focus on that.
Yeah, so that's the term, that myopic term is called bikini.
So at least even we may continue with the bikini health. Still, it is okay, but they should also not forget the heart.
Yeah, so I think Dr. Usha, I always remember that when you.
Interesting.
The
That's very
bikini
interesting.
doesn't include the brain. So I mean, it's not something that I coined or anything. It's there. The bikini view of women's health. That's what it is, which is looking only at, breast issues or reproductive health issues. And, people like Dr. Vogman and others have really expanded this whole conversation to include stroke and heart disease and osteoporosis and musculoskeletal health and mental health and, the whole thing. So, and that's so important. And they're all interconnected also. So depression increases the risk for, makes diabetes worse. They're all, bidirectional also. So, yeah.
Great, true. So I'm going to be shooting questions to some of the other Indian experts who are here. I wanted quick inputs from Dr. Annabelle as she's joined us. One quick question, madam, and an answer. Do you find reservation for women in the area where you practice about taking statins? We very often come across it's not gender specific, you have that, but sometimes I feel women have more reservation for taking statins because of possible side effects. Do you come across that kind of a problem?
Absolutely. Yes. I thank you for asking that questions, because I wanted to add that in my talk, I'll talk about the use of coronary artery calcium score to convince women because they can't really understand the concept of a risk in the next 10 years. But when they see that they are developing calcium in their arteries of the heart, it's personal, and they are much more willing to try the statins before they would not even entertain it. They've heard that, it causes dementia, it causes problems with the muscles. And so there's a lot of reluctance. And on a daily basis, when I see these patients, there's so much reluctance, unfortunately. But we're lucky now that there are so many new drugs for cholesterol lowering that we can choose them quickly change to those if they don't tolerate them.
Right. And the other thing, we spoke about how women have not been included in the trials to that extent. So it was a delight to see the data for SELECT trial, which is your cardiovascular outcome for semaglutide. And if I'm not mistaken, almost 75-78% were Caucasian women in the trial in the SEMA cardiovascular outcome study. So things definitely are changing in terms of women inclusion in the trials also, which gets me to take the next question to Dr. Lothika. Lothika, you practice in arguably the more sophisticated part of Mumbai, away from suburbans like us. But do you still come across health disparities for women in South Mumbai? And do you think, the role of societies and organizations, so you work with the Rotary or Lions Club, you think there is a role of these organizations in championing the cause of women's health? And as I said, the first part of the question, do you really see disparities in women's health or preference in diabetes management in the more affording parts of the city or the country?
Yeah.
So thanks, Manoj, for asking me. First of all, thank you, Purvi, for inviting me for this lecture series. And so, Manoj, yes, I do practice in South Mumbai. I see the affluent. I also am a visiting faculty at JJ, where I see the other side of the coin. So there is disparity everywhere, I feel. More so, of course, in the lower and middle socioeconomic population, wherein the women are not given their due, and most of them themselves do not ask for attention, especially if they have like what is the low health seeking behavior. Only if it's a real big problem will they really go to the doctor, because it means that they have to ask their husband or their son or somebody in the family to take them to the doctor. Yes, affluent people, of course, are very quick to make a phone call or to seek an appointment, but still they require something for it to be that they cannot deal with on their own. And then they probably will, if they feel it's something big, is when they really seek an appointment. Also, like Dr. Bansi said, there is like a fragmented care model. So the first person that they do seek in is sometimes a gynecologist or a GP, and who probably may or may not be the right person to guide them regarding their blood sugars or their lipids or blood pressure and their goals. And of course, cost and access is another thing that is, there. So yes, there definitely is a disparity.
Right. Wonderful. And you think the role of the organizations can
Oh,
help
yes,
change
the
that? Yeah.
organizations can help. Yes, I am with the Rotary, and this year I'm the chairperson for the lifestyle diseases. So yes, we are looking forward to doing a lot more, awareness programs, and to get people to, at least have themselves tested for the blood sugar. Like, there are a lot of people who have not checked their blood sugar in many years. And like Dr. Bansi said, that, it's the fifth vital sign that blood sugar at least should be tested every time a patient sees a doctor. Also, NHbA1c should be done yearly. There should be, yearly checkups, so at least biannual checkups for women, not just to screen their breast or to have their, cervical examination done, but their blood sugars, their lipids, and blood pressure also should be examined.
Thanks, Latika. So let me take this question to Dhruvi. Dhruvi, I'm not asking you a question. I'm narrating a story first and then asking you a suggestion. So there is this lady that Purvi has been treating for PCOS, and she's been on the therapy for the same. The other day she came to Purvi and said, "Ma'am, that prick got me pregnant." And Purvi was asking, "Which prick are you talking about?" And she said, "The semaglutide prick got me pregnant." So this is taking the question from Dr. Ripun's question, that somebody being treated for PCOS on SEMA, what do you advise? Somebody who gets pregnant while treated for PCOS, what do you advise moving ahead?
So thank you, Manoj, sir, for the question. It is very interesting when somebody comes and says that they got pregnant because of a prick of semaglutide. It was very well actually shown in Meena ma'am's slides that somebody who is on management of PCOS, metformin and lifestyle modification are the only answers. A woman who is of a childbearing age, she needs to be explained and counseled that she should not get pregnant on the GLP-1 therapy whenever it is ongoing, or for that matter, on any other OHA whenever that lady is being managed. These women need to be educated and counseled very well. So if this particular lady who came to Purvi ma'am and said that, she got pregnant with a prick of semaglutide, I don't think that's possible. That's a very paradoxical situation you're putting me in when I'm answering that. Purvi ma'am, thank you for having me on the panel today. So maybe this lady needs to be checked first of all, whether her UPT was correctly positive. It wasn't a false positive, and there could be other reasons why her hormonal level could be
So,
deranged.
Dhruv, it's absolutely possible, right? Somebody is losing weight on
Somebody
sema,
losing weight and still
and,
not
and
taking a contraception properly, she could get pregnant.
so
But she
that's a
needs to
scenario
be.
which you will face, any of us will face. Now, whatever has to happen has happened. The prick, whichever prick has done the job. Now, what do we do moving ahead?
We ask the gynecologist first to assess the congenital anomalies of the fetus, properly scan whether the fetus is healthy or not, and then take the corrective action for whatsoever path the lady wants to choose. And if all's well, of course, immediate cessation of GLP-1 if the lady wants to continue with the pregnancy. That's the answer. And if not, again, it's on the lady and the gynec together with us to decide what she wants to do as a measure for this current situation.
Okay,
Manoj,
Dr. Vipul
can I
wanted to.
add something?
Yes, ma'am. I know this is a controversial question, so please, all
No,
of you
no,
can
this
quickly add it.
actually, no. I just want to say that there are, a flip side also to this coin, which is any woman with known diabetes that we are, or even PCOS we are treating, right? Even metformin can induce ovulation.
Yes.
It doesn't have to be semaglutide or tirzepatide, but I'm saying even metformin, if now pioglitazone is coming back thanks to this role in MASLD and things like that. So both these drugs can cause unplanned pregnancies. So I think every woman who walks in and Benny, and why I wanted to jump in was Benny and I were working on talking to Dr. Guillermo Pierres about including this in the guidelines, saying that one of the important steps is if it is a woman of reproductive age, right? Then there are a couple of things like, is she on the right, is she on, have contraception? And does she know about this? And only then prescribe anything, including metformin. Now, coming to these semaglutide and tirzepatide, there's actually a bunch of Ozempic babies who have been born. So I think it's really important that when these medications are being considered, right, contraception counseling is a must. And only if women are willing to, be on that, because they're going to end up in, however, if we can reassure there are babies born with this, nothing happened to them, we can wait till the anomaly scan, we'll wait for this. Still, it's going to cause a lot of distress in their head about having been on something. So any woman with diabetes, PCOS, or an ovulatory cycle, any of the medications we are using, including metformin, we absolutely have to make sure that they are on the right contraception. And that's a very important step in the management of women with diabetes.
Yeah, Dr. Saula, let me clear this. This is in fact a real scenario.
Right.
The lady has been on the diabetes. She is known to be diabetic. She was and since the last 10 years, she was trying for pregnancy, but it was a total failure. But she was prescribed Ozempic, and she took few injections up to the 1 milligram, the full dose. And after taking one dose of Ozempic 1 milligram, and she got pregnant. It was an accidental pregnancy, and her even gonadotrophic hormone also gone up to 300 and something. So far I know. So it's a pregnancy is confirmed. But I'm asking for any further, precaution we should take or we should advise to the girl.
I think there's some data coming out about the safety of possible safety of semaglutide in pregnancy. There have been unplanned pregnancies and babies born who, like I said, are being called the Ozempic babies. So far, no signals as far as abnormalities. But obviously, we can't do that. These kind of unplanned, they happen. But we cannot do it unless there's data, safety data, and FDA clears it for us. But there are some observational things going on semaglutide in pregnancy.
Madam, I just want to tell everyone that, what I do in my clinical practice, if I writing some medication, which I don't want that person should become pregnant. I mean, the female should become pregnant. After writing the medication at the end, I ask that, can you please sign yourself and write that I will not be pregnant on above medication. So I will take all due care for that. So if they sign on their own, they write it, and this is written for all females below before the premenopausal women. And we ask them, you please. So many of the times we are writing them lipid lowering agent, ACE inhibitor, ARB, they are on Ozempic, they may be on different medications, and this they have to sign themselves and they write it down. So then they remember, by all means, they will not be pregnant. And when they come back and they say that accidentally they become pregnant, that you have written that this is you will not do.
Yeah.
Now decision is all yours, because this you may consider now to continue, not to continue. It's all up to you. But I think they are not safe. That is what is written, and it is not officially approved.
Yeah, and it's not approved. It's not approved.
I mean, this is what not
not
approved mean. It is we don't have the data at present.
Data.
And then
not to be given.
even the gynecologist and
Bansi, anecdotally, Dr. Meena was saying that she's had such cases where she's used Mounjaro, and then because Mounjaro is a dual agonist, the lady got pregnant with twins. But this is all anecdotal, and I think we can continue this wonderful discussion with the
because
lovely
now we are
panelists.
writing so many patients the Mounjaro and all newer medications, and it is not, none of them is approved, and we are writing to 30s, 20s, and even very young girls.
Sort of caution. Yeah.
Well, as I said, we would love to continue this discussion, but we are well beyond our time. So I'm going to stop here and thank all the panelists for joining in. Thank you for having me on this wonderful panel and discussion on this great day where we remember Dr. Beni Neglur and we miss her so much. Let me hand it back to Dr. Purvi and Rutul to take this ahead for our guest speakers talk as we move ahead. Thank you all for being here.
Thank you so much. That was a very interesting panel discussion, very enlightening too. But we move on, and we have none other than Dr. Annabel Bogman joining us today. And I have to thank Dr. Usha Sriram ma'am singularly for making this happen. We are so excited and elated that you're here with us to talk to us about the cardiovascular risk in Asian women. We learned a lot from the Masala study, but we are really looking forward to what you have to share with us today. And to formally introduce her, I'm just grabbing this opportunity from Rutul and Dr. Abha, and I'm just going ahead with introducing Dr. Annabel. Yes, Dr. Rutul did give a great preface to her introduction that she has been the face of Go Red, and that has been a very inspiring movement for all of us here in India as well. And thanks to Dr. Usha Sriram, who actually has sort of conditioned all of us to think in that direction. So without much ado, yes, Dr. Annabel Bogman is the Macmillan Ibel Endowed Chair for Excellence in Clinical Cardiology. She's the Professor of Medicine at Rush College of Medicine and immediate past medical director at the Rush Heart Center for Women. Also the Director of Research and Academic Affairs Division of Cardiology and the past governor of American College of Cardiology of Illinois. We welcome you, ma'am, and if it's our good fortune, we'll soon have you in India physically with all of us to share your expertise and experience.
Thank you so much, Dr. Chawla, and thank you, Dr. Sriram, my dear friend who invited me to speak to all of you. I've been so thrilled to be part of this. Learned a lot from Dr. Meena, and I hope that we can continue to learn from each other. I wanted to just share the outline of my talk. I was asked to talk about cardiovascular risk in Asian women, but I think it would be good for me to talk about cardiovascular disease in India. So I'm going to give a general talk about the general perspective of cardiovascular disease, and then compare the United States with India's risk of cardiovascular disease, and then specifically about cardiovascular disease in India. And then I want to share with you a SCORE 2 paper that was published just recently. in how we can predict cardiovascular disease risk in Asian countries. And then talk about diabetes and CVD, as you've already been talking about, but I wanted to give you my take on that. And then just briefly talk about some of the new forms of cardiovascular disease in women. So we were invited to write a paper on the global perspective on socioeconomic determinants of cardiovascular health. This was we published this last year, and I invited my colleagues from all over the world to help me write this paper. And as you know, socioeconomic determinants of health is probably more important than the work that we do in prescribing medications and diagnosing diseases, because it affects so many of the population. This is the global burden of disease caused by cardiovascular disease in both sexes of all ages and percent of deaths. And I just wanted to show you how it's been increasing in the last few decades. In 1999, you can see the numbers here. The percent of risk of deaths from cardiovascular disease was 27.3. And then it increased to 29.8. And then in 2019, it increased to 32.8. So we are seeing an increase in cardiovascular deaths as people develop more economically, and we are spreading the Western diet to all over the world and increasing obesity and hypertension all over the world. So we need to help in helping our patients, but it's really the governments and the health insurance companies that can really make a big dent in how we can decrease cardiovascular deaths in all over the world. Let me see if I could advance this. So in India, particularly, there are now 1.4 billion people in India, and it's the most populous country in the world. When Dr. Shriram invited me to go to India a few years ago, China was still the most populous, and it was predicted by 2023 that India would be the most populous, and it has now become the most populous country in the world. So there's a lot of Indians in India, and also in a diaspora of Indians all over the world is amazingly large. And there has been a general increase in cardiovascular deaths, disease and deaths since 1990. And unfortunately, cardiovascular disease remains a leading cause of death in India and disability. So the prevalence of cardiovascular disease in India is 422 million people, and it's responsible for 27% of all deaths among Indians. Interestingly, as we were discussing that the urban areas is a particularly higher risk than the non-rural areas. And you can see here that we found that the CAD prevalence of Indians living in the urban areas was nearly double that of the non-rural areas. So the non-urban areas. So 13.2% in the urban areas and 7.4% in the rural areas. So it might be the pollution and the stress that can contribute to that. As you can see, it's not just the care of medical care, but it's the environment, the social determinants of health that we need to pay particular care, that we are also minding that. And I know that there's been a lot of papers about pollution that is causing increased myocardial infarctions, and we need to do what we can to help our environment to be healthier for all of our citizens. During a 7-year follow-up period, the prevalence of obesity increased from 9 to 21% in men and from 13 to 25% in women in India. Hypertension has increased, as you can see there, from 11 to 34% in men and 5 to 15% in women. And the prevalence of diabetes has doubled among men and women, 5 to 12% in men and 3.5 to 7% in women. And although the prevalence of cardiovascular disease has been rising, the burden of cardiovascular disease has shifted from Indians of higher socioeconomic status to those with lower socioeconomic status. And this is particularly problematic because the lower socioeconomic status people will have less resources to help with their diseases, affording their medications. So this is a particularly problematic situation for Indians. There are also markers of multiple factors such as income, education, diet, and the state of healthcare system that all play an important role in the burden of CVD. So it's not just doctors who need to be talking about this. It has to be the politicians and the healthcare systems that need to help us decrease the cardiovascular deaths in India. So that was our global perspective of socioeconomic determinants of health. And I just wanted to point out that we need to involve, when we have these discussions, maybe we should be inviting our politicians and our healthcare this healthcare system providers. Here in the United States, we have many private insurances in addition to Medicaid and Medicare. So we need to involve them in the discussion and when it comes to decreasing cardiovascular disease. So I wanted to show you this paper that was very interesting that was published in 2018. So granted, this is 7 years old, but it compared cardiovascular disease in India with the United States. And the prevalence of cardiovascular disease in India has risen over the last 26 years because of population growth, aging, and a stable age-adjusted cardiovascular disease mortality rate. And in the same period, in the United States, we have experienced a decline in age-adjusted cardiovascular mortality. Unfortunately, the trend has not only begun to plateau, but has become increased. So unfortunately, we are now seeing an increase again after all the efforts that we've done to decrease cardiovascular deaths. Since COVID, we have seen an increase in cardiovascular deaths. And I can show you slides about that, but I wanted to concentrate on India. So this is in 2018, the rates age standardized of ischemic heart disease throughout the country of India. The blue and the light blue are lower risk. This is deaths per 100,000 people. And as you can see, I noticed in Chennai, which is where I was with Dr. Sriram, it is a higher risk. And then up here in the northwest region is even higher risk for ischemic heart disease deaths. If you look at what is happening in terms of behavioral risk factors, why is it going up in India? You can look at tobacco use, low physical activity, and dietary risks. And as you can see in India, it's been increasing over the decades. It has not decreased as much as it has in the United States. But like I said, it's going up as well in the United States. So both countries have to work hard to decrease cardiovascular deaths. So over the last 26 years, we saw that blood pressure, total cholesterol, fasting blood sugar, and BMI have decreased in the United States, but not in India. And over the last 26 years, the dietary risk, tobacco use, and low physical activity have improved in the United States, but not so much in India. And I wish we could tell you that that trend has continued in the United States, but as I said, it is not. So we do need to worry about that. When I was part of the committee on women and special populations at the American Heart Association, I wanted to write the scientific statement paper because I have been informed by many of my Indian colleagues that cardiovascular disease is very high among South Asian people, and it was not being recognized by physicians of different ethnic backgrounds. So because we keep lumping the South Asians with the East Asians, and that decreases their risk. So we wanted to write this paper just to showcase that atherosclerotic cardiovascular disease in South Asians is very high, and it's a major cause of deaths and disability among them. So we found that South Asians in the United States have a higher proportional mortality rate from ischemic heart disease compared with other Asian ethnic groups, especially the East Asians and non-Hispanic whites in the United States. And in the United States, the greatest risk factor disparity in South Asians was seen because the South Asians have diabetes and impaired glucose tolerance, and that South Asians have at least twofold higher prevalence of diabetes, a higher incidence of new onset diabetes, and a higher prevalence of impaired glucose tolerance compared with non-Hispanic whites. So I have received many citations because there's a lot of interest in cardiovascular disease in South Asians. And this has, I think, helped a lot of American doctors to appreciate the risk of cardiovascular disease in South Asians. And unfortunately, it is also very high in Filipinos. And we are also writing papers about that. I wanted to talk about the SCORE2 risk that has been used all over the world. And it's very similar to our ASCVD risk score, the pooled cohort equations that we use in the United States. But in addition to the usual risk profile, it includes the risk of the geographic region. So it's a low risk geographic region. It is incorporated in the score. But it includes sex or gender, age, whether they smoke, and systolic blood pressure and total cholesterol and the lipid panel. There is a SCORE2 without diabetes, and there is a SCORE2 with diabetes. This particular paper that I'm going to talk about was the SCORE2 without diabetes. So what this paper did, which was just published in February of 2025 in the European Heart Journal, was to look at the 10-year, an estimation of a 10-year cardiovascular disease events in patients without cardiovascular disease or diabetes in the Asia Pacific region. And they looked at the different, this region had the same risk that they are attributed to. And then they looked at the different countries in which their scores fell into. You can see here Australia and New Zealand have the lowest risk region, as well as the Korean region. And then the moderate risk region are yellow, and there's only one country that has that. The high risk region includes India, China, and some other countries. And then the very high risk region was in the Middle East and in Mongolia. So very interesting. In terms of what low risk means, it's different for women and men because men will have a higher risk of cardiovascular disease, fatal or non-fatal events. So for women, a low risk is 6%, and a high risk is 22%, the same as men. But for men, even a low risk is higher than a woman's risk at 10%, and moderate risk is higher than the women's. And when it comes to the high and very high, very similar in both sexes, as you can see. What they did was they looked at the score and different blood pressures and lipids, and then whether they smoked or they did not smoke. And as you can see, in even the low risk CVD, the men who smoked, who have high blood pressure, who are older, still have a very high risk of having a cardiovascular event, whether it's fatal or non-fatal. So fatal or non-fatal CV events, even in the low risk group, the men had a high risk. So it gets worse as the risk goes up. This is the moderate risk. And then for the high CVD risk, as India is in, and then the very high CVD risk, the risk is much higher in these groups, the older they are, the higher their blood pressure, the higher their cholesterol, and whether they smoke or not smoke. And you can see in the very high risk, it's very similar between women and men, whether they're going to have a fatal or non-fatal cardiovascular events. So I thought this was very interesting. And then they looked at the different countries. As you can see here in India, between men and women, they are very similar in that if they're very high risk, they're going to have a increased percent of fatal or non-fatal cardiovascular events. And then the very high risk groups, as I said, was mostly in the Middle East and also in the Philippines and in North Korea. Very interesting. So these are the same people as the South Korean, but because of social determinants of health, the North Korean have a higher risk compared to the lowest risk in South Korea. So it just goes to show you that social determinants of health is so important when it comes to even the same kind of people that have this problem. I'm going to shift now to diabetes and cardiovascular disease in women. And as you know, as we have been talking, as you have been talking throughout this conference, that women have a higher risk of mortality when it comes to cardiovascular disease if they have diabetes. So occlusive vascular mortality, coronary heart disease, and stroke risk are higher for women with diabetes compared to men. And the coronary artery calcium score is such an important tool that I use, and we are now using in the United States. So we now offer it for almost free to be given to the population so that they can understand that when they have coronary artery calcium in their own hearts, they become much more motivated to take the statins and to take this seriously. So I really would like to encourage all of you to use coronary artery calcium score because it's such a great motivator. But as you can see here, women with diabetes, these are women and men with diabetes, if the CAC score is greater than 401, their risk of mortality rate in women is much higher than those of men. But when it comes to coronary heart disease, it's about the same. So it's the non-coronary heart disease in women that we are seeing, whether it's HFpEF or stroke or hypertension related diseases. But it's still that occlusive coronary artery disease is seen more as much in men as it is in women with diabetes. So it's very interesting that women with diabetes still have the same risk as men when it comes to coronary heart disease. So as I said, we are really committed to our population here in Chicago, and we're almost offering this coronary artery calcium score almost for free. And I actually went on TV encouraging all people to do it. And if they can't afford $49, to let me know, and I will pay for their coronary artery calcium score. And that's how much I believe in this tool that we have been using. And we get so many patients because they have a high coronary artery calcium score that they didn't even know about. I know we talked about diabetes medications, but I wanted to give you an idea from a cardiovascular standpoint that we as cardiologists are now using and learning to use diabetes medications because it not only treats diabetes, but it prevents cardiovascular disease. This is a list, and I'm not going to, show you all the different diabetes medications. But look at this green, where blue is no effect and green is some benefit. And as you can see, the green is really concentrated on the GLP-1 receptor agonists and the SGLT2 inhibitors. So as cardiologists, we have learned to use these new drugs because we are learning how to protect our patients with diabetes from cardiovascular disease, including major adverse cardiovascular events, CVD death, myocardial infarction, stroke. Heart failure is a big risk in women, and atrial fibrillation also with the GLP-1 receptor agonist. So very interesting new drugs that we have learned to use, and we use it with caution. We feel very comfortable with the SGLT2 non-diabetes dose of 10 milligrams. But when it comes to diabetes doses, we really work with the endocrinologists and the internists to make sure that they are in synchronization with our therapy for decreasing cardiovascular events. I wanted to show you that this consensus decision pathway in patients with heart failure with preserved ejection fraction, because I think it's particularly important for women. So we diagnose HFpEF, or heart failure with preserved ejection fraction, using this wonderful algorithm that's so easy to use. And I teach everyone about this because until this came out, we really didn't know how to diagnose heart failure with preserved ejection fraction. And I talk about this because it's the SGLT2 inhibitors that are really helpful in these patients. So to diagnose HFpEF, you can use this algorithm, and if they have greater than or equal to 6 points, it's highly diagnostic of heart failure with preserved ejection fraction. And it's easily available to everybody. If they have atrial fibrillation, that is a huge risk for having a heart failure with preserved ejection fraction. It gets 3 points. But if they're heavy with a BMI of greater than 30, they get 2 points. If they're on 2 antihypertensives, they get 1 point. And if they're older, greater than 60, they get 1 point. So even without an echocardiogram, which are the other 2 parameters, you can diagnose a lot of patients with heart failure with preserved ejection fraction. So if your patient with diabetes has complaints of shortness of breath or some leg swelling, please consider this diagnosis for them, because it's easy to treat these patients now that we have the SGLT2 inhibitors. There are some sex-specific differences when it comes to HFpEF. When a patient with heart failure symptoms present, if they're women, it's usually HFpEF. If they're men, there's a higher risk that they have heart failure with reduced ejection fraction. And this may be because there are greater attributable risk from traditional risk factors in developing HFpEF in women, including hypertension, diabetes, and obesity. And then also preeclampsia and central obesity. Women have more dyspnea and worse comorbidities, so they have worse health status. And some echo findings that we all are also seeing in women. And you can see here in this consensus statement paper, the #1 treatment that we are using for these patients are the SGLT2 inhibitors. I have come to learn and to love using SGLT2 at 10 milligram dose, because I have so many patients with HFpEF who complain of shortness of breath. And besides exercise, the best thing that I can give them is a low dose of these SGLT2 inhibitors. I cannot tell you how grateful my patients are when I start them on these medications. I do warn them about the UTIs, and they are actually okay with that, because once they start using it and they feel better, they said, I'll take the UTIs, just treat me for the UTI, and I want to continue this medication. It's really amazing. The other thing I wanted to point out with this is, of course, we can use loop diuretic agents when the patient has leg swelling or shortness of breath. But the other things that women can benefit from more than men are the mineralocorticoid receptor agonists and the ARNIs. The only one that we have is Entresto. So it's a valsartan sacubitril. That's an ARNI. And all women, no matter what their ejection fraction, for both of these are beneficial for women. But for men, it's interesting. their EFs, they don't benefit unless their ejection fraction is low, less than 55 to 60%. But for women, doesn't matter what their ejection fraction is, they're going to benefit from the SGLT2 inhibitors. So very interesting new information that we're finding. So just to briefly show you the new forms of heart disease in women, we've learned to study spontaneous coronary artery dissection because this occurs in pregnant women. If a woman presents with myocardial infarction during pregnancy, the number 1, 2, and 3 that should be in your list of differential diagnosis should be SCAD, and they need to be treated appropriately. And it's very difficult for interventional cardiologists not to put a stent when they're having an MI, but if you can avoid a stent, that would be better for them. And then you've heard of INOCA, which is ischemia in myocardial infarction with non-obstructive coronary artery disease. A lot of women have microvascular dysfunction, stress cardiomyopathy, pregnancy-related heart disease, rheumatologic-related heart disease that we are recognizing the risk of patients with rheumatoid arthritis and lupus, and they start getting heart disease early on. And then, of course, cancer-related heart disease, because they're treated with either radiation therapy or chemotherapy that can cause heart disease. So these are the papers that we've written over the years to try to help women with heart disease. And I've been very fortunate to collaborate with so many of my colleagues here in the United States and around the world to write about heart disease in women. So when it comes to women and cardiovascular disease, we celebrate at the American Heart Association after 21 years of going right for women. We've come a long way in understanding women and cardiovascular disease, but we still have a lot to learn. So thank you for your attention, and I'm happy to answer any questions. Thank you.
Thank you so much, Dr. Annabelle. That was a fantastic talk. We anticipated this, but you really, got our focus on cardiovascular disease and the rising prevalence and the differences in men versus women beautifully. Thank you so much for that. Let me
I
just.
have a question.
Yes, please.
So, at what age would you recommend doing a coronary artery calcium in non-diabetic
Great.
women and
Yes, that's a great
hypertensive
question.
women?
So for women without diabetes, I recommend it at age 50, and then for men, age 40. But with women with diabetes or other risk modifiers such as lipoprotein A or rheumatoid arthritis, we're actually about to do a study in that in patients with rheumatoid arthritis and lupus, starting at young ages. But I would start at age 40 because it's such a low risk scan. It's a CAT scan, which is about the same radiation risk as going up on an airplane. So, and it's so inexpensive. Insurance companies don't pay for this. So that's why we're giving it at such a low rate, low cost to our patients.
So you're recommending as young as 40
in diabetic women, yes.
Women, yeah.
Yes.
Ma'am, would you be able to clarify a bit, because we have always traditionally heard that although the coronary the coronary calcium score is such a high value test for screening women, it also is sort of clouded by the presence of diabetes. So a lot of cardiologists in India do believe that it's probably not the best test to screen, but would you be able to clarify that a bit?
I'm not sure what the reason is for saying something like that. I would have to look at their data.
Because older age women may have calcium deposition and not actually a plaque, is what she's asking. So is it as so?
any calcium in the coronary arteries, you have to assume that it's atherosclerotic. They are at high risk.
Yes, and one can always confirm that with a traditional angiography if required.
So we recommend a coronary angiogram in anyone with a coronary artery calcium score of greater than 300, or at least a stress test. So if you identify these women or men with a score of 300 or more, you want to make sure that they don't have left main disease or triple vessel disease that would require either coronary artery bypass graft or stents.
That's right.
Can oral calcium supplementation in high doses lead to atherosclerosis? And
That's a great question, and my patients always ask me that. So hopefully you're all endocrinologists, at least most of you are, I think. You know, the parathyroid hormone is supposed to be regulating calcium, right? So it's not as simple as whatever you take in orally calcium that would go into the coronary arteries or the valves. But I do believe that if there is some dysregulation of the parathyroid hormone, such as the vitamin D deficiency, that it is possible that you can take too much calcium, because a lot of women are being told to take as much as 1,000 milligrams of calcium when they're already eating foods that have calcium. So they're probably eating much more than they should. And you know, you guys know better than I do when it comes to the regulation of oral calcium and the deposition of calcium in different organs.
Yeah,
What do you guys think? What do you
Annabelle,
guys think?
No, Annabelle, I think hit it absolutely spot on, that we should encourage our, patients, our women, to make sure they have adequate calcium in their diet, and they have the sun exposure, because many are vegetarian and there's no vitamin D in the vegetarian foods. So the sun exposure. So because food is not fortified with vitamin D as it is in the West here. Except some places milk is fortified, but not all the milk. So sun exposure is still the best. So women need to be advised on calcium containing foods. And there's a lot of myths and misconceptions, Annabelle, about they tell people with diabetes, don't take anything that's white in color. What they mean is salt, sugar, flour, and also include dairy in that. But dairy is such an important thing for women. So we also need to dispel a lot of myths about what they can and can't. And I think 500 milligram of calcium postmenopausal women, because it would be a crying shame if we fixed their glucose, but they had a fracture.
Mm-hmm.
So
yeah, osteoporosis is another big problem that I get so many questions about, because
yeah, and it's also more in women with diabetes. So it's important that we need to balance both of these things. And a lot of people, you're absolutely right, were taking lots of calcium. They thought more of a good thing is better. It's not. And so those are all things that we need to counsel them. But definitely that concern about the coronaries getting calcified because of 500 milligrams of calcium, I think is a bit of a stretch.
I agree.
I think another thing that I notice is that there's a gap in recognition of this cardiovascular disease risk and screening in people with diabetes, and particularly the primary prevention really suffers, because we are still struggling with diabetes and pre-diabetes awareness. And you add cardiovascular health to that layer, that layer to the entire problem, then it multiplies. The thing is, the cardiologists have their screening recommendations in place, but it's the diabetes and endocrinology forums that do not. So our guidelines need to be updated and made even simpler because today diabetes in India and probably everywhere else, it's also the primary care physicians that are heavily involved in treating this. So I think that's a gap that we need to bridge with such webinars.
See, Purvi, still I think one of the best studies, in my lifetime is the Steno study, Steno 2, that said that if you, address the glucose and the cholesterol and the blood pressure, you get a much better response, right? So as physicians and endocrinologists, we need to be focused on those things, right? And as Annabelle said, we need to then start thinking about, after a certain age, about screening for cardiovascular health. But the risk factors, I think, play a bigger part.
True. And also, we often don't pay attention to the fact that it's a J-shaped relationship between dysglycemia and cardiovascular risk, because as you don't want the uncontrolled glycemia, you also don't want hypoglycemia. That would also add to the cardiovascular risk burden. And I think today we have more and more technology to help us assess that and address that. And I think that's where technology also can help at least prevent one part of the spectrum and lead to better outcomes. Any thoughts, any comments on that?
Yes, because I actually showed that case also. One of my type 2 diabetic patient reported with her children who refused to take her to the hospital because she complained of mild breathlessness and anxiety. She went to a hospital where she was dismissed as anxiety neurosis and given a tablet of clonazepam. So we need to be more careful. We generally brush the symptoms under the carpet, saying, and when women complain of breathlessness, and if they happen to be obese, we tend to tell them, we brush it under the carpet by saying you are breathless because you're obese, you don't exercise. So I think, like Dr. Annabelle pointed out, we must keep our eyes open for diagnosing heart failure with preserved ejection fraction. We should be doing more and more what Purvi said, more and more echocardiograms. We should be doing the NT-proBNP, and we should be proactively doing the CSE to rule out coronary artery disease, because the patient then came to our hospital in the morning when she had infarcted, and we had lost that window of opportunity where she could have been, subjected to an primary angioplasty. And her own children said that mom is always anxious. So she was dismissed as anxiety neurosis. We tend to call our women hysteric, anxious, when they complain of aches and pains, and we tend to dismiss it. So again, a very strong message is that women have to be treated. I mean, when they're saying they're breathless, we have to treat them. I mean, we have to listen to them. So it's important to listen to the symptoms because they may be different from classical symptoms of angina. So that is important. We should not miss the elephant in the room, not miss, heart failure with preserved ejection fraction or reduced ejection fraction.
Thank you, Dr. Meena. We have the same issues here in the United States, unfortunately.
Mm-hmm. Great. So Dr. Rutul and Dr. Abha, do we have any more questions?
So one last question I have. When would you prefer doing a stress echocardiography vis-a-vis a calcium score or a treadmill test? Only a treadmill test or a stress echocardiography or a calcium, a coronary artery calcium score? How would you?
Thank you for that question. It's a great question. So we use the coronary artery calcium score in asymptomatic patients. If they are symptomatic, you need to use other diagnostic tests, such as an echo and a stress test. So the nice thing about what we are doing here at Rush is that in addition to a nuclear test, we do a PET test, which also looks for coronary microvascular dysfunction, and we include a coronary artery calcium score. So it's a very comprehensive stress test when we do a stress PET. But short of that, We only use the CAT score for asymptomatic patients. And then if a patient is symptomatic, you have to do a diagnostic test of either an echo and a stress test.
Thank
or
you.
both.
Thank you.
You're welcome.
Great. So I think this has been a really fulfilling webinar. And I would think that, a great tribute to Dr. Benny Neglur ma'am, who was a champion of women's health. And we lost her too quickly. She would have loved to be a part of this. And I think nothing better to commemorate her anniversary. With that, I hand over to Dr. Ripon sir for offering the vote of thanks.
Thank you, Dr. Purvi. Good evening to you all. And first of all, we know this webinar is dedicated to the loving memory of Benny Neglur. We all know she has devoted her life to the upliftment and betterment of women's health. So at the very outset, I would like to offer my thanks and gratitude to Dr. Vijay Neglur for gracing this academic feast in the very beginning. And my thanks goes to all pioneers and executives of Diabetes India, including the chair and co-chair of this particular forum, Diabetes and the Women, Dr. Purvi and Dr. Rutul, for this beautiful talk and well-organized execution with a grand outcome, of course. It's very fantastic. My thanks and gratitude to all the faculties and speakers for the excellent insight and really, really very good amount of learning tidbits. Dr. Usha Madam, Dr. Meena, Dr. Dhuvia Shani, Dr. Lotika Purohit, and above all, Dr. Annabelle Bhogment, and of course, the smiling gentleman, Dr. Manoj Shavla. Dr. Abhay and Rutul for excellently conducting this webinar. And above all, any webinar is fruitless without the support, without the participation of our learned audience. My thanks goes to all who attended this webinar and make it a very grand success. And not the last one, of course, there's, at the end of my thanks goes to RX event, to especially Mr. Jogas. Without their support, we cannot organize even a simple webinar or any academy. And at least if I haven't missed anyone out here, thanks to Torrent Pharma for the kind support with a token of love to Mr. Pandit. So that's all. If I am fortunate, I haven't missed anyone more. Over to you, Purvi. Thank you.
Thank
Good night
you
to all.
so much. And really special thanks to all our faculty today for this, for sharing all your expertise and experience with us. We will continue to bug you, to ping you and rope you in to guide us further. And our mentor, Dr. Banshi Sabu sir, who has really been a huge source of inspiration and motivation to get such programs ahead and always ensure that they are a good quality education, material or content driven. And also Dr. Amit Gupta, whose enthusiasm and whose vision for the interest groups continues to guide us as well. So with that, I thank you all very much for today, and we will meet very soon.
Dr. Annabelle, can we
Have
share
a
heart
And
failure
big
with,
thank for Purvi Chawla.
can we share it with our audience, with everybody? The mnemonic that you gave us for heart failure.
Sure. I'd be happy to send my whole slide presentation if you'd like, and the paper on that HFII.
Yeah, thank you so much.
Dr. Vogman, I have one more request. If you could record a video for us, and on
But today we would have recorded, Purvi. You just asked the
that's
RX
the
event.
entire talk, but if you could record a video for the people living with diabetes in general, especially women, just a minute or 2-minute message from you, I think we would share that. You could actually say it right now. We'll record it right now.
And Purvi, later on, we can do a podcast also with her.
Exactly so.
And that we can put on our website. And today, the recordings, if RX event people are there, we can curate the recordings of only madam, and that also can be put on our website too.
Absolutely, sir.
So later people can listen, or we can share that link of that to also to all our members. Once again, thank you, Anala. Very, very good. Fantastic.
Thank you, Dr. Vansi. Good night. Good night.
Yeah.
Thank you, Bansi. Thank you,
Have a
everyone.
wonderful day.
Thank you everyone. Thank you, Purvi ma'am, for the wonderful organized webinar. Thank you, ma'am.
Purvi, you wanted to record that, so then we can ask you.
I do want to record that.
Yes, yes. So let us talk to the. Hello, anyone from RX
The
event?
recording is on, so we can.
RX event is there. Then
Yes,
we can ask madam to do the recording.
Sir, recording is on, so if we record right now, it is
It will
okay.
be-
We'll just
Okay, but then
crop
we
it. We'll edit it.
all of us can off our video and let
Yes,
only
yes, we
madam
can.
and Purvi,
We'll off
both
our
of you
video.
can be there only. Is okay? Just Dr. Purvi and Dr. Anamila, only their 2 photos come. We can.
Go ahead, ma'am.
Thank you so much for letting me record this. So women with diabetes are at much higher risk than men with diabetes when it comes to major cardiovascular events, including fatal and non-fatal heart attacks. So please, if you have diabetes, whether you're a woman or a man, please make sure that you're getting protected for preventing heart disease, heart attacks, and strokes. Thank you.
Thank you so much, ma'am.
I hope that's good enough.
So hope to see you in India soon.
Thank you. Thank you for the invitation. And thanks, Dr. Sriram, if you're still there.
I think she's logged off, but I will follow it up with an email or message.
Thank you so
Dr.
much. everyone.
Planning to have the next. Dr. Purvi.
Let's decide soon on our group.
Okay, fine. Thank you.
Bye, so bye.
Bye.
Okay, good night. Good night, everyone.